All right, everyone. So it's now 5 past the hour. I think we're gonna go ahead and start. Okay. So just a little background about me. So I'm a urologist, and my practice is based primarily at University of the West Indies and University Hospital of the West Indies. But I also see patients privately in Spanish Town at Dharma Medical and also in Edgewater at Edgewater Medical Center currently. I'm a senior lecturer at the university where I supervise, and I'm program director of the residency training program. So that's a program where we train residents to become experts or consultants in urology. And I have been a urologist for several years. And one of the things that I know is that technology is necessary for the advancement of our specialty. And we have seen quite a great increase in technology. I would say maybe in the last 5 to 10 years in managing many conditions, inclusive of BPH. And so tonight's webinar really is to bring to the attention, bring to the knowledge of you, members of the public who are interested, to hear about this new groundbreaking technology that we happen to have in Jamaica. Please feel free to ask as many questions as you can. And if I'm going along and there's a question that is burning, feel free to type in the chat and I'll try and address it as much as possible. Let me say, first of all, thank you to MITEC for allowing me to present in this platform. MITEC is they're the company, a subsidiary of Boston Scientific, which provides this groundbreaking technology. So I thank you for allowing this to happen. And thank you, of course, you, our attendees. So let's get into it. The prostate gland. So the first thing we have to talk about is where this gland is. The prostate gland is located below the urinary bladder. It wraps around the urinary passage called the urethra, and that's that tube that runs from the bladder neck to the tip of the penis, and that's the urethra. So the prostate wraps around the upper end of it. It also, in relation to the rectum, lies in front of that gland, and so it lends itself to easy accessibility for examination by inserting a finger there, and it also lies behind the pubic bone. Now, this gland is going to get bigger and it enlarges with age. And one of the reasons we are talking about this technology today is because of the effects of enlargement on this gland with age. There is a purpose or function to the prostate. Many patients ask me, can I function, can I live without the prostate? And my answer is always yes. You can live without your prostate gland, but it does have a role. And it's an accessory gland of reproduction. It secretes fluid that comes out in the semen when men have sex and ejaculate. So this fluid is called prostatic fluid, and it contains nutrients, contains substances that help to make sperm healthy and strong, essentially. So it facilitates the whole reproductive process. And that's its job, really. But despite doing all of this, as men get older, this gland gets bigger. But prostate enlargement is inevitable. No man can live without having an increase in size of his prostate. The average growth rate that you can see here from this study is 2.5% per year. But this is an average. You have some men who have a lower growth rate and others where it's much greater. And we know because if we have men in our offices where we see them every year and we do an ultrasound every year, we do find that the prostate gets bigger and bigger each year. And what comes with that increase in size is the presence of symptoms. So the problem is great. We know that you have this condition called benign prostatic hyperplasia, which, if we were to ever get a biopsy of the prostate, we will see enlargement. Apart from this enlargement that we can see structurally, maybe with an ultrasound or a CT scan, we see that there's an increase in number of these cells that make up the prostate. These are glands that make the secretion, as I said to you before. They're also smooth muscle cells. So the pathologists, if they get this tissue, they can say, yes, they see increase in number of cells, they see increase in number of smooth muscle cells. And this is classically how BPH looks. And all men over age 40 are susceptible to having an enlarged prostate called BPH. The enlargement is benign, so it's benign prostatic hyperplasia means that there is no cancer present. And in some of these men, they will have benign bladder outlet obstruction, so-called BOO. And of course, they will manifest with what we call lower urinary tract symptoms or LUTs. So there's at the top, those are some of the few terminologies that we like to use in urology. This chart really just shows you what an autopsy study some years ago showed us, almost 40 years ago actually, that if you were to do an autopsy on men at different age groups for various reasons, and this was actually a study that was done in Detroit, and most of these men died because of trauma, gang violence, etc. But they decided to do this study to see of these men, what were the sizes of their prostate at various ages. So for men in their 30s, only 8% of them had an enlarged prostate. But look what happens once they got into the 50s, the 60s, the 80s. 50% of men in their 50s had an enlarged prostate. 70% of men in their 60s and 90% of the men in their 80s. So what we saw is that drastically as men got over the age of 40, there was an exponential increase in the size of the prostate. And so yes, BPH is a disease of the aging male. Now, not all of these men who had an enlarged prostate would have had symptoms. So another study was done, which is called the Olmsted County study, where they looked at how many men in these various age groups, age bands, had symptoms or bother from the enlarged prostate. Not just to say, okay, we found it on clinical exam, we found it on ultrasound. How many men were now bothered? And they found that for men in their fifth decade of life, so in their 40s, 24%. So almost a half of those who were found to have an enlarged prostate now had symptoms. And again, like before, we found that the presence of symptoms increased with age. And so we see that it's a disease of increasing age, and it's a disease where symptoms are likely as men get older, starting at around in the 40s. But what are the typical symptoms of an enlarged prostate? Does anybody know? Well, a common thing that men will tell us is that their stream is weak. And sometimes the men tell us, or sometimes the partners will tell us. I've had men tell me, listen, the stream feels okay. But the partners will say no. They listen. When the man goes to the bathroom, it may take a long time to initiate the stream, or the stream is weak. And so we find that that's a common symptom. The stream, the force is weak. Now, because BPH is something that occurs slowly over time, men compensate and they figure, you know what, it's all right. They'll tell you it's not like when they were younger, but it's okay. But the important thing I want to emphasize tonight is it can be better, and we do not have to accept what is less than normal. I'm so surprised many times when I've been seeing patients and and I've been treating them maybe with medication for years. And when you ask them at each visit, whether it's every 3 or 6 months, they'll say, you know, the stream is okay. But if you objectively measure it, it's very poor. But the problem is that they have gotten accustomed to this. They think it's something that they must accept with aging, and they're bothered. And we want to talk tonight about the fact that men do not have to be bothered, and there are options, and options that are tolerable and effective. So the stream is weak. Sometimes they have to strain to urinate, or there's hesitancy. So the patient says, yes, I want to urinate, but when they go to the bathroom, they have to whistle, they have to think, they have to relax, and after a few seconds, the urine comes down. That's what we call hesitancy or intermittency, where in the middle of the stream, it stops and starts, stops and starts. And this is all because of the obstruction. Sometimes men will tell you, okay, I've urinated, but by the time I pull up my zipper and I walk off, there's some dripping coming down because they haven't emptied well. And the worst thing, I suppose, is that of urinary retention, where the man wants to urinate and nothing at all comes, and that's an emergency. A catheter has to be fitted. And 30% of men who develop urinary retention will eventually have to have some invasive form of surgery. Other symptoms men may have, maybe about 2/3 of men will tell you that they have increased urinary frequency. They have to go often. Sometimes they can tell you, listen, if they're taking a drive from here to the country, they have to make various stops. If they're at work, they have to break meetings to go and urinate. At night, they have to get up several times to urinate. The urge is great. If they don't get there in time, it comes down on them. These tend to be bothersome symptoms that typically men who have an enlarged prostate will have. So the big thing I always try and find out from patients is, how does this affect your quality of life? Is your quality of life impaired? And that's most important, because quality of life is what's important to all of us, right? How does it affect you? Can you live and do you live comfortably? And just to know that there are options for you where your quality of life can be improved. So let me give you a patient experience, and this is a real life patient experience of one of my patients who has an enlarged prostate, and I recently treated. So this is a 45-year-old male whose occupation is that of a soldier, and he works very hard and long hours sometimes. And as you know, sometimes soldiers are posted in places where they really have to stay there and they can't move. They can't rush off to the bathroom, otherwise things will happen. So having good urinary control and good flow is important for these people. He started to notice that for 4 to 5 years, he was having bothersome urinary symptoms. He had no other medical problems. He was healthy and fit and well. And on physical examination, when I saw him, I found that his prostate was enlarged. I made him do an ultrasound, and the ultrasound confirmed that the prostate was enlarged. So for those of you here who have gone to a doctor, who've been told about their prostate and how big it is, we say it's enlarged if it's greater than 30 grams, or the radiologist may say 30 mils. Anything above that is enlarged. So based on his ultrasound, he had a mildly enlarged prostate, 37 grams. But despite that, he was quite bothered. And I'm not sure how well these slides project, but the top slide shows a tracing from what we call the patient's uroflow. So if any of you have been following our Instagram page, Urology Solutions JA, you'd see where at one point in time we spoke about the uroflow test, which is a very simple test that is a standard in our office. Any man coming through has this test done. And all he needs to do is to come with enough urine in his bladder. Doesn't have to be completely full, but at least enough urine. He pees in a container. The container measures the volume of urine over time and creates a flow rate, and it creates a curve. So at the top, what you see is this patient's flow rate, which was lowered. The maximum flow rate we expect for a normal male should be anywhere greater than 15 or 20 mils per second, meaning the patient should be passing at least either 15 to 20 or greater mils per second of urine. Instead, for this guy, he was passing 5.7 mils per second. And this was something that we documented every time he came. So his symptoms were corroborated by what I saw. So before he even came into the office, I could tell that this guy was bothered, and especially at such a young age. And what I'm showing you is that in the bottom curve is what it should look like. So in the middle, what we are seeing here is a normal flow rate curve that looks like what we typically call a bell curve. But this patient, going back to the curve at the top, was obstructed. So I diagnosed him with bladder outlet obstruction that was due to an enlarged prostate. And as natural, which is typical in most of our clinical settings, I started him on medication. And so for those of you online, you may be aware of a medication called Duodart. And Duodart really is 2 drugs in 1 tablet: tamsulosin, which is an alpha blocker, which is a smooth muscle relaxant for the bladder, which is to help improve urine flow rate, and Avodart, which helps to reduce the size of the prostate. So naturally, we started him on this medication just to see how well he would improve. And also what I typically do in office is that with each visit, you are going to repeat the urine flow rate, which is simply takes seconds. And so we can judge with each visit what improvement we're having from our medication. But there was very little change that he noticed at home, and very little change that we noticed on his flow rate when he came to his office. And he emphasized just how much this condition was impairing his quality of life, especially professionally, based on what he did. So the other thing that he complained about are the side effects of the medication. So the Avodart, which is contained within the Duodart, is a drug that helps to block testosterone from its most active form. And in doing so, it can help to reduce the size of the prostate, but it can also affect things that are important for testosterone to do, inclusive of libido, that is drive or interest in sex, inclusive of erectile function. So he was noticing that there was a reduction, a sharp reduction in his interest for sex. His erections were weaker. He would have sex and not see much coming out in terms of ejaculate volume. And that was important for him because still at 45, he was a young male. The tamsulosin, which is other component in the Duodart, also can drop the blood pressure. And this guy who had no chronic illnesses and he was normotensive, meaning his blood pressure was normal, the tamsulosin component was able to drop his pressure. And he didn't like having to take a tablet every day. So he wanted more. And so these were the options I gave to him. I said, you could continue to take the tablets, or we could opt for what is considered the gold standard, which is the transurethral resection of the prostate, or resume water vapor therapy. And we spoke about each option, risk, benefit, and a decision was made. So what did we say about the medication? Well, it was expensive. Yes, National Health Fund covers many of these drugs, which is good, and many of our patients take it, but long-term, there's a cost. Either there's a cost borne by the government, which is ultimately coming from taxes from our citizens, but also there's a copay that patients have to take for the rest of their lives. And as I said before, BPH is a condition that is going to increase in prevalence with age. So if this guy started off at 45 years taking medication, he would possibly be taking it for the rest of his life. So there's that expense. The need for daily dosing, which was inconvenient for him really. The sexual side effects, and what we didn't even speak about were the cognitive side effects, which are real from these drugs. Now, the drug Avodart is a second generation from the prototype drug called finasteride. And many of you don't know, but finasteride is a drug that has been used over the years to help hair growth in men. If you ever know of this drug anybody ever heard of the drug minoxidil? Minoxidil used to be used years ago for men and probably still used to help grow hair. So if there's baldness, men could take it and it could help increase the hair growth. And that was using finasteride at 1/5 of the dose that we use for an enlarged prostate for BPH. But they found that for a lot of the men who were using this drug over time, they had these sexual side effects. So this is at a lower dose. They had sexual side effects, and they also noticed cognitive side effects. So they started to talk about these finasteride syndrome, or the syndrome that occurs with use of these drugs. And you can imagine the doses that they were being used for these men was 1 milligram, whereas for BPH it was 5 milligrams. And they've recognized that even those who took Avodart, the effects were the same. At the university, where, as I told you, I'm the program director, we are involved in a lot of research. And so just recently published is this paper where we reported on the prevalence of these 5-alpha reductase inhibitors, so that's Avodart, the adverse effects in patients with BPH in Jamaica. And what did we find? We found that erectile dysfunction and sexual dysfunction was quite significant in these men, and it was seen as early as 6 months after initiating therapy. So once men started to take it, within 6 months, they started to notice either libido was low, erections were weak, ejaculation absent, and they just felt lousy. We didn't see the cognitive side effects, but we think that that's something that occurs with longer term use. And other papers have said it occurs over 18 to 24 months of use at least. So, and of course, there are other issues such as depression, suicidal ideation, anxiety, and breast swelling, many things that men would not really want to tolerate. So the other option we spoke about was the transurethral resection of the prostate. This is a procedure I was trained in, and I continue to do and continue to train our residents in and offer it to patients. And it is considered the gold standard. That means anything new is compared to it. So if any technology comes about, you have to say, how does it match up to this procedure? Well, for the TURP, men need to either be put to sleep or have spinal anesthetic, and therefore it has to be done in an operating room. Men are kept overnight for at least 2 nights. They have a catheter while in hospital. There's irrigation going. It is an effective way of treating enlarged prostate. And the picture shows you what happens. A scope is introduced in the urethra and the tissue is shaved away. Not the entire thing, just the obstructing part. There are risks, however, risk of bleeding either during the procedure or after. The risk definitely of lack of ejaculation, just like what happens with taking the deodorant, and it's permanent. Erectile dysfunction is a low risk. Stricture or scarring of the passage is a risk. It may fail in some men, and they may also get a UTI. So then we spoke about Resume, which is this groundbreaking technology. And I told him about the pros and the cons, and I compared it to a TURP. So a TURP uses electrical current connected to a wire to resect or shave. The Resume uses steam to ablate or kill prostate cells. The TURP, as I said to you before, must be performed in a hospital-based setting where a patient gets general or spinal anesthetic. The Resume is commonly performed under local anesthetic or a little bit of sedation. The TURP requires hospital admission. The Resume does not. You do the procedure, you go home the same day. The TURP is a longer operative time, typically an hour, hour and a half of resection. The Resume, each treatment, each injection in the prostate is 9 seconds. So if on average we give 6 injections, you can do the math. 6, 9, 54. The entire treatment period is less than a minute. What may take a little longer is the prep, the setup, giving the spine, giving the local anesthetic, putting the patient in position, inserting the scope. But essentially, the treatment period is short. The complications from a TURP are far greater, potentially, and certainly not just the surgical complications, but the potential medical complication if patients are not fit for anesthesia. There are far fewer surgical complications from the Resume. The recovery is slightly longer for TURP. Sometimes up to 6 weeks, patients will have bloody urine, they'll have burn non-urination, they'll have frequency. The recovery generally for the Resume is much faster, and they can go back to work quicker. TURP has a high success rate, hence it is considered the gold standard treatment, but so does Resume. And a TURP is much more invasive, but Resume is much less invasive. So what's our patient? What did our patient opt for? Well, naturally, this is a guy who's a soldier. He doesn't want to take time off for long periods of time from work. He was convinced with the science. He did his research. He did his background evaluation. He went to the literature. He went to Google. He saw the reports of patients. He was happy to go ahead with the Resume. He was not interested in the invasiveness of the TURP, and he certainly didn't like the pesky side effects of the medication. So he had Resume done. And at the time of his surgery, he came in, he started, the procedure was to make sure he had a negative urine test before to ensure that he wasn't coming in with an infection. We had already had labs for him in the office, so we made sure that his blood count was okay, he didn't have any kidney impairment, and that and overall he was in a good shape. Now the truth is, you can be in bad shape and have Resume. We just want to know that we can adjust our medication and our dosages, right? But I think the most important test really is the urine culture, that there's no infection. He started antibiotics the day before. He walked in the office. He got antibiotics on the table. We gave him a transrectal block. So we put an ultrasound probe up the rectum to numb the prostate. He was awake. He spoke to us throughout the procedure. We inserted the device in the urethra, and we injected 6 times in the prostate. So for each injection, it lasted for 9 seconds. Once the procedure was finished, we inserted a catheter, and he had his catheter removed after a week. Now, if you remember what his uroflow looked like before his surgery, you remember how flat that curve looked. His maximum flow rate, that's the peak flow rate, was 5.7 mils per second. And we said that was reduced. We would expect for his age greater than 15 or preferably 20. At 2 months post-op, this is his curve to the left, 16.5 mils per second. And at 3 months post-op, it's 23.3 mils per second. And that's current. That's as current as we get with his outcome. Needless to say, he's happy. His erectile function is preserved. So his treatment did not affect his erectile function. He ejaculates normally because with a TERP, he would lack ejaculation, and as he lacked it with the duodart. And his urine flow is as strong as ever, he said, like a 16-year-old, in his own words. So how durable is it? Because I think that's what a lot of people question. With new technology, is it a fad? Will it last? Well, we have the data. Just to let you know, Resume was FDA approved. That means approved by the FDA in 2015. So in order for it to be approved in 2015, you would have had about 2 to 3 years of patients being enrolled in trials, clinical trials, and outcomes being gained. And of course, the FDA reviewing the outcomes to see if this was something that should be allowed or not. And so it's been around, at least FDA approved, for 10 years. We've had it in Jamaica since late last year. But if we look at the data from North America from the initial trial, the 5-year data that was published about 4 years ago, the outcomes are excellent. If we look to the graph to the right, what we see is the maximum flow rate at the first instant at baseline. You see it was about 10, and then you can see at 3 months, it's between 15 and 20. And what you see is that it's pretty good still over the period of time. You don't have a precipitous drop. So over the 5 years of the 60 months of watching these patients, they've maintained their good flow rates. The success rate is in the order of 94%. It's sustained, it works. If we ask patients to complete questionnaires, which we do for all of our men, we ask them to complete a prostate symptom questionnaire to objectively document how they are at the beginning, and through treatment, we find that at the beginning, a lot of them are bothered. Their scores are very, very high. But after treatment, it drops. The scores improve. It means they feel better, and it is maintained. So yes, it is durable. So the preparation is easy, and I'm going to show you this video. So if you think, okay, when I'm preparing my patients for a TERP, because I know they're gonna get either spinal or general anesthetic, I need to make sure they're in their best possible shape. And most of these men presenting for a TERP are in their 40s, 50s, 60s, and above. But they have other comorbidities. Some are very ill, some have had heart disease, some have stents in, some are on blood thinners, and some anesthetists may not be comfortable putting them to sleep because of the risk of bleeding or another heart attack or a stroke. So I have to send the patient to do all these laborious labs. They have to do sometimes an ECG or an echo to make sure their heart is steady and stable. They have to do a chest x-ray before even being considered for surgery. That's not needed in this situation because of how minimal invasive it is. It's probably the better option for patients who have multiple comorbidities, and there's no age restriction. Yes, the American Neurological Association added Resume to the procedures for treatment of an enlarged prostate just last year. And they said, yeah, you want it for men at the age of 50 and above, but it is at the discretion of the physician. There's no science or no miracle with age 45 or 50. If men have an enlarged prostate and they're bothered, they can get it. And there's no cutoff. The oldest patient I've treated is somebody who's in their 80s, who had multiple medical comorbidities. So surgery was definitely something he said he did not want, and his family did not want. So let's just look and see a little bit about the technology and how does this thing work. So that's it. And I think it's remarkable that somebody thought of this, but also just how simple. And this is how I look at it. You put some boiling water on the pot, a pot of boiling water on the stove, and you throw a tomato in there. And what happens? It literally shrivels up. In this scenario, what is happening is that if we just take away all the jargon from convective energy and thermal energy, it's heat. The heat causes the cells to die. And the cells may not die right away, but with time they will. And what many patients have said is that they find that over time, the symptoms improve. So you can even see in our patient that we mentioned before, that at 6 weeks, he had significant improvement, over 100% improvement in his urine flow. And even now at 3 months, it's even greater. So progressively there's improvement because of the effects of what the heat does. And heat is safe. It's not going to cause any stricturing or scarring within the passage. It doesn't go and penetrate beyond a certain depth because of how it is delivered. So you have minimal scarring or little or no scarring and minimal tissue damage. Some patients will notice that they even pee out fragments of their prostate tissue in the urine. Others will just notice that the flow just gradually improves. So the flow improves, urinary frequency is less over time. So in summary, Resume, it's safe, it's effective, it's tolerable, and it's durable, and it's a good and wholesome treatment for BPH. So I'm gonna open up the floor for questions now. I see quite a few people online right now, so I'm sure there are questions you can you can type in the question and answer session and I'll be happy to answer if there are any questions currently. Well, then maybe I should ask, is there anyone here who has BPH and can you share how you are treated for your BPH? All right, no questions yet? All right, so there's one question, and that question is, what lifestyle changes can I make to support my treatment and overall prostate health? So excellent question. There's not much lifestyle treatment you can make to prevent BPH, to be honest with you. For persons who have BPH who have mild symptoms that are not bothersome or they're called minimally bothersome, trying to avoid certain things in the diet, which we know can irritate the bladder and worsen frequency, is one thing that we do. And certainly in persons who have just had Resume, you want to avoid the irritants in your diet. So these are what we call bladder irritants, things like sodas, which I guess we probably shouldn't really be having anyway. Lots of spicy food, caffeine, um, anything that has a high citric acid content, because these things will cause irritation of the bladder, cause burning. Post Resume, it can cause more burning. So probably those things you want to avoid in the early phase when there's inflammation. So how the procedure works, as opposed to a TURP where you cut that tissue out, we take it out of the prostate, and you have immediately a wide passage. With Resume, once the steam is injected, there is inflammation, and that inflammation can last for the period of 2 to 3 or sometimes even more weeks. So anything spicy, soda, alcohol can cause burning and worsen the symptoms. So you probably want to stay away from those things. And certainly alcohol in men who have BPH is never a good thing. I can't tell you how many times throughout my training or even now as a consultant that I've had to go to the emergency room for some man who knows he has BPH, but goes out drinking. Sometimes it's a night, sometimes it's a, what's it called, round robin, drinks a lot of alcohol, the bladder becomes over distended, the bladder doesn't contract well with alcohol, and they go into urinary retention. And sometimes even after they've sobered up, they're unable to void on their own. So you really want to avoid that. I find a lot of over-the-counter prescriptions, things that have anything that says multi-symptom. It is the multi-symptom component is pseudoephedrine. We used to have a drug called Sudafed, then now have it as Histal, DC. So the pseudoephedrine in it helps to drive nasal secretions, but it can also cause the bladder neck to contract. And if already you have an enlarged prostate, that can create challenges in emptying the bladder. So that's general advice for persons who have an enlarged prostate. But yes, in the post-Resume treatment period, stay away from the sodas, alcohol, and the coffee. Someone says, I'm prescribed Silarel. My flow is not a real problem now. And that's great. And this is what I say to patients. There are options, but patients must be open to options. Who are candidates for Resume? Is it only a patient who has a problem with the flow? No. There are some men who I have seen whose flow is okay, but guess what? They don't want to take a tablet every single day. They just would prefer not to have to for the rest of their lives. There's a cost associated with the drug which they can't bother with, or the side effects. I mean, just this week I had a patient who was prescribed Silorel for a week, and he said, listen, he measures his blood pressure at home and it went down, and there were sometimes he felt a little woozy. Some of these drugs, based on how they work, can act on other receptors, and it can cause a drop in the blood pressure. So yes, there some, if patients are comfortable with their drugs, their flow is okay, frequency not a bother, they're not bothered by the adverse effects of the drugs, fine. But I heard someone who has had a lot of experience with Resume say, for some men, they consider it just a treatment. Almost, I won't even say it's prophylactic, but somehow it is a treatment that helps them from progressing to the point of urinary retention are really, really significant bother. That being said, we don't have any evidence to corroborate that that is necessary, that should be done. But there are patients who do Resume, not because they're bothered, but they just do not want to take tablets anymore, despite having a good flow. Someone says, what about female regularity? I'm not sure what that question refers to. Maybe you can type and ask, explain exactly what you mean. Someone says, how soon can I return to normal activities after the procedure? So it is variable. As I said, it's done under local anesthetic. Well, that's typically how I do it. There are some persons overseas who sedate people, give them IV sedation, and they go home the same day. I give oral sedation, you go home the same day. You have someone drive you home. You have a catheter in. You probably want to restrict heavy lifting and strenuous activity for a few days. And depending on how long we keep the catheter in, which could be a few days or a week, you can resume your normal activities, resume, pun. So you can resume your normal activities maybe after, maybe I would say about a week, which is typically what I say to patients. But I always tell patients in the early period after the procedure, things can kind of get a little rough because there is swelling to the prostate, there is inflammation, the flow gets a little slower until the inflammation subsides, the resorption of the cells occurs, or you pee out the fragments, and then you start to notice after 2 to 3 weeks, beyond that, 6 weeks, beyond that, the flow is significantly better. So restriction of normal activities, for most persons, it's a week. And that doesn't mean you can't work. It just means you're not doing anything strenuous. You're not having intercourse, right? Someone says, I'm currently on Duodar, but I'm not sure if it's working. How costly is this procedure? And this is something we can discuss privately. What I've put here is our contact information. 876-360-6720 is a WhatsApp number for our office. And we like to say the treatment is personalized. The first is to do an evaluation and to see if you are a candidate. Not everybody's a candidate, by the way. Size of the prostate matters, and we have to measure and see. Now, the guidelines currently say your prostate must be 30 to 80 mils to do this procedure, but we're never shackled by guidelines. Guidelines are guidelines, but we have to manage patients. And many studies have shown that even persons with prostate volumes over 80 grams are candidates for the procedure. And I've done patients with 80 grams and they've responded. I probably would not go over maybe 100 and odd grams or so. So we can have discussions. The procedure is covered by health insurance, major health insurance companies, and very much so to a significant amount, so we can see. All right. Someone says, I currently have a tubing to help me urinate. Can I be helped? Absolutely. And this is such a great question because, yes, men who have a catheter in can also do this procedure. And we've done this procedure, certainly on today, 2 patients who've had catheters in. And I can tell you, early data on the first one, he's passing in and passing in well. And in his own words, better than before he even went into urinary retention. So yes, it can be done on persons who have a catheter in. The difference is we may keep your catheter in longer than someone who came in without the catheter in, but yes, it is possible. Foods to avoid, are there any proven foods to promote good prostate health? Very good question. Randomized control trial, best level of scientific evidence? Answer is no. We do not have any strong scientific evidence that there is any food that can promote good prostate health. So yes, I see all the YouTube videos about the lycopenes and the zinc and the whatnot, and those are good, healthy options. But do they promote good prostate health, as in prevent BPH? No, they don't. They really don't, right? Hence, we're here. Is there any truth to treating the loss due to BPH with the moringa plant? And again, that's touching on the same thing. Excellent question, Mr. Johnson. And there is no evidence. I know there's so much out there. People are saying so much about things, patients buying things, but we don't have any scientific evidence that those things work. What about frequent urination in women who don't have UTI? Do you cater to women as well? Well, yes, as a urologist, I treat both men and women for urological conditions. Although our talk tonight is focusing on BPH and men, yes, we do. I do treat women who have frequent urination, whether it's due to an overactive bladder or something else. And that treatment is specific to that, and we can discuss that at another juncture. Again, here the phone number is 360-6720 for WhatsApps to make appointments. All right. So, are there any other questions? None? And so, yeah, I mean, oh, I think someone is typing a question. So, yeah, I mean, Duodart is probably one of our biggest selling drugs. And if you look at data from an NHF, it tells you how many scripts have been written for Duodart. But the truth is, Duodart has its own set of side effects. And so we like to know that we do have options there. And remember, once patients do this procedure, they don't need to take the tablets anymore. No need for any further Cilarel, no need for any further, Duodart. All right. So is the procedure covered by health insurance? It is. Sagicor Medicus covers this procedure in Jamaica. And their response is pretty rapid. It covers both the surgical cost and the cost for the device. A lot of men have been very happy that it does so. All right. So lots of good questions so far. So I see two questions coming in. And what is the top age to get this procedure? Well, let's say starting age 40, because that's when BPH starts. And guess what? I've had men younger than 40 having BPH. Um, you know, I can think of some men I've treated over the years. Their symptoms started at about age 38, 39. In fact, there was one guy whose BPH symptoms started at about 38. He had just gotten married. He was trying to have a child. His prostate size was like 70 grams. Remember, I told you upper limit of normal would have been 30 grams. He would have recurrent urinary tract infections with a fever, like 2 to 3 times for the year. He had to be going to his family doctor, being treated with prolonged course of antibiotics, really bad urinary symptoms. He got married around the same time. He needed to be treated, but we had to be careful what we gave him because this is a young man who is married who wanted to have a child. If I gave him Cilarel or Flomax or any of those drugs, it could affect his ability to ejaculate. If I gave him Duodart, it would affect his libido, his erections, and his ability to ejaculate. So we're so very guarded in terms of what we gave him. And at the end of the day, I think his treatment was suboptimal because at that time we did not have this option, right? He did not want the TERP. He couldn't get the TERP anyway because, again, if you do the TERP, you would not be able to ejaculate. So you would not be able to have a child normally. So these were some of the challenges that he faced. So yes, Carlisle, after the procedure, no need for tablets. Now, there can be regrowth of the prostate tissue for any surgical procedure that you do for BPH. When it's a TERP, for a TERP, we tell patients the prostate can regrow after 10 to 15 years because we don't remove the entire thing. The only time we remove the entire thing is if it's cancer. Remember, this is not cancer. For Resume, based on the data that we're getting so far, and I think perhaps by the end of the year, we're going to get even 10-year data, it seems to be comparable to the TERP where regrowth is probably not before 10 years. So what happens once we do it after 8 weeks, 8 weeks after the procedure, when we know inflammation is probably at its lowest, you stop taking the tablet. Do you need a referral from your GP to come in? No, you can come right over. The numbers are here, 360-6720, Mona Institute of Medical Sciences. Patients don't need referrals. Patients have emailed me. Patients have just sought us out because they're looking for something that is non-invasive, that is durable and effective for them. Yes, Carmen, we do treat erectile dysfunction because unfortunately, this is one of the conditions that men at this age also get. And this is something that we can speak about as well and offer some help. So I'm very happy for the feedback and the questions that we've been getting. I think I see Prince has been trying to write a question for a little while. Let's give him some time to send in the question. Question is, where's the treatment done at UE? No, we do it currently. We do the treatment at an outpatient facility in Kingston, but that may expand to other locations soon because this is a minimal invasive procedure. It can pretty much be done in any space where there is a small surgical center. You don't need to have an anesthetic machine there. But no, the treatment is not currently done at UWI. The consultation is done at UWI, and then we arrange a treatment elsewhere. So typically when you come in the day of for the treatment, your time in the office is usually, I would say, anywhere between an hour or two because you come in, we do checks, we ensure that we do a urine flow possibly before the procedure just to see where you're at. Patients normally take an oral sedative like an hour before the procedure starts. The procedure is done, the actual time of the injections is short, but the setup may take a little longer. Once the procedure is done, we see the patient with whomever comes with them, usually a wife, to go through again the post-op period and what's expected, and they go right home. We always follow up several times just to make sure all is well. And once the procedure is done, we see patients after to remove the catheter. And after that, we see them 6 weeks after the procedure to do urine flow rate to make sure objectively they're doing better. 3 months after that, and after that, you may just go once a year to see your doctor. So the WhatsApp number is on the screen. It's 360-6720. So that's 360-6720. And I think there's some other questions coming in. And the Instagram account is at Urology Solutions JA. And it's a good place to go so you can see some of the videos that we have there for patient information, what to expect, what the procedure is like. So feel free to go to our account at Urology Solutions JA. Thank you, Mr. Johnson. I thank you that the information was good. And I really hope that everybody here was informed. I see women are here, and that's important. Yes, as a urologist, I treat women as well. For Olivia, who's been asking questions, you can feel free to contact the office. But for those of you who are here who either have problems with their urine or you know of anyone, it's important to note the technology is here in Jamaica. I'll tell you a little secret. Several years ago, maybe about 2 years ago, I had a flurry of questions from patients sending emails to me asking if we offered this procedure. And do you know why? Because so many of their relatives in North America had been doing the procedure and had been telling them, listen, it's a game changer. Do you have it? And do you know how crestfallen I felt as a urologist practicing here and trying to teach and teach what is stand of care and not being able to say, yeah, you know what, we offer it. All I could say is, no, all we offer is the TERP at this point in time. And the TERP will never go away. There are some people who have to have the TERP. Some men who have an enlarged prostate come in with heavy bleeding, they have to have a TERP. Resume cannot help them. Some men who have a big prostate, who have a stone, they have to have a TERP, right? So there are certain indications for a TERP you cannot get rid of. But the point is, for patients who want the ease and comfort of a minimal invasive procedure that is safe, that is durable, we do now have it here. Men don't have to fly overseas to have the procedure done. All right. So someone says, can the procedure, when after the procedure is done, can the patient drive and work out? So normally I would say that they restrict strenuous physical activity at least for a week. I mean, I did a procedure on a patient about a month ago, and he had already planned to do a marathon, one of those 5K, sorry. And I told him probably not to. He planned to do that at 2 to 3 weeks. I thought it was too much for him at the time. And even though he was feeling well and urinating okay, I thought exertion of it may have precipitated a bit of bleeding, or so I told him to hold off. And he felt better not doing it. So I would say the patient won't drive immediately after the procedure, because whether you know it or not, you literally sit on that area of the prostate. Probably shouldn't be doing much cycling either. And I tell patients, don't do strenuous activity for at least a week. All right. All right. I think I see two more questions or comments coming in. You are most welcome, Carlisle. And there is hope for all of you. Um, all of you who have issues with enlarged prostate, there is hope. All right. Any questions? You're welcome, Thomas. All right. All right. Thank you, everyone. So I think we have probably spoken about most of the issues that I would like to say about this. So for all of you who joined in, I'm appreciative. I know 7 o'clock is typically dinner time or almost bedtime in Jamaica. So thank you for taking the time. Thank you for the interest. And I just like to say, just spread the word, spread the news that this is here and it is new. Thank you so much. All right. Have a good night, everyone. Thank you. Thanks, Tangini.